Good evening, everyone. How are you all? All right, so welcome to First Aid AMC MCQ again. I hope that so far you guys are enjoying our free sessions. And obviously, we had our first free session a couple of weeks ago, and that was one on psychiatry basics, right? Tonight will be our first class on the free 2-week session. As you can see in our Facebook group that like we always offer our students to go through our classes at least for the first 2 weeks so that they get to know about us. And obviously you need to find out that if you are interested in something like this, and if you think that the classes are helpful for your preparation or not. And I know that there is a lot of people who offer just one free trial session. And I always say this to everyone that please do not get it blindly, because like anyone can take a very good class and they can choose the best topic that they usually know about. And taking a class just for the first time and one single class, that can be really good, but eventually you might end up finding that course not very helpful. So always at least take 1 to 2 weeks of free sessions from anywhere that you want to enroll so that you get to know about them and then find out if it is helping you or not. That is the safest way to enroll any of the courses. So that's the reason why we offer it. Previously, we also used to just do one free trial session, but then we thought like, well, this is not something fair for the candidates. So to become more fair, that's why the free 2-week sessions are going on for the last few courses, I guess. So I am Dr. Arshan. I'll be your main mentor for the 5-month MCQ course. And I understand that many of you are already enrolled in our course, and some of you are still looking for these trial sessions and find out if it is helpful or not. So there was a little bit of mismatch about this topic of today's session, I guess, in the Facebook group. I think today I say that it will be a cardiology session, but it was actually my mistake because we had our tips and tricks to solve question as part of our today's schedule for a long time. So we will do the question solvation tonight, and the next class will be cardiology class. All right. So that schedule was given to your Facebook group a few weeks ago. So let's start our question solvation. So you get to understand from here is that sometimes theory knowledge is important because getting the knowledge of theory will help you to solve these questions eventually. So there is a lot of things will happen in someone in the Facebook group or someone in Messenger or in WhatsApp group. They will just say that just solve some questions and you will pass the exam. It is not that easy, honestly speaking. And I feel like they also don't do that. This is just some kind of misguiding, all right? So just solving the Q bank, just solving some month's questions, that will you will most likely end up failing the exam eventually, and then you will understand the mistake. So rather than going into that direction, you should make sure that you have a fairly good knowledge on theory, and then you can easily use that knowledge on any questions that come in your exam. So exams are going to get difficult each year. So it doesn't mean that if you just solve few questions and that will just come in your exam. It's not something like that. So please make sure that forget that idea in your head. Whoever is saying those kind of things, it is just misguiding. So please don't do that. Now, today we are going to show you that how actually you should solve questions and how to make sure that you don't fall in the trap of the examiner. So you know that when an examiner makes a question, they have something in their mind. So when you are solving that question, you have to think that what examiner was thinking at that time. So that's how you know that what can be the trick or trap of this particular question. So we try to find out what is the trick or trap of the question and what is the tip of that question. Because in a question, there will always be some tips to this question answer. So you need to find out that tips. But on the other hand, sometimes in the question, you will find out that something is very evident, like the question seems very easy to answer. Most likely, that is actually just a trap. Okay, so always think deeply when you are solving the question. Something which is very evident and it is just given on the top part of your question, it's very unlikely that the answer is that easy. It's just to make sure that you feel confused and get your wrong answer in the exam. So we are going to show you how to deal with this kind of trap in the question, because that's where the candidate get it wrong. So how normally we do this question solvation? So we go through some random questions, we discuss the questions, and always make sure, along with the question, know about the theory of that question. Like, let's say you are solving a question from cardiology, and let's say you got a question about pericarditis, and you don't have much idea about it. So what you will do? Will you just memorize the answer of that question? No. You should read acute pericarditis, like what is the history, what's the investigation we can do, what is the management of this condition, and what is the ECG finding. So you just make sure you know about the theory when you are solving some questions. So that's how you prepare yourself. You just don't memorize questions. You don't just memorize the Q bank. That is not the way to know about these topics. So any new topics, any new questions you are getting, make sure you immediately just read the theory either from the JM or from anywhere, like the Australian guidelines are there. So you just make sure you read the topic from that, from any of the available resources. And that way, eventually you will find out that a lot of topics has already been covered just by doing that. And there will be no new topics left which can appear in your exam. All right, so lots of chit chat, right? Now let's start our first question. So you have got a previously fit 55-year-old man who has undergone an emergency right hemicolectomy for a perforated cecal carcinoma. 2 days after the operation, you note that following his fluid balance sheet, patient had a IV input of 2 liter, nasogastric aspiration 2 liter, drain losses 700 ml, urine output 500 ml, and also all the electrolyte values are given in here. Which of the fluid balance regimen below would you order for the next 24-hour period? So this is 2 days after the operation. You have got a patient who is having certain kind of input and certain kind of output. So this is basically a question of fluid balance in the post-operative period. Now, when a patient is in post-operative day 2 onwards, the fluid balance is important. You have to find out that what's the input and what's the output. And based on that, if output is much than your input, then you have to give some more fluid so that patient doesn't get dehydrated. Conversely, if patient is getting more fluid, output is low, then you reduce the amount of fluid that you are giving to the patient. So that's why having a strict fluid balance chart in the post-operative period is very important. Now, how we normally measure that? First thing first, you need to first find out which is more, input or output. So this patient input is, you can see that intravenous input is 2 liter. So 2 liter is the input. Now come to the output. Patient has an output of, so obviously nasogastric aspiration is the output, so 2 liter. drain 700, urine output 500. So we have got 2 liter, then 700 ml plus 500 ml. Now there is always some insensible loss that you can't see. So sometimes from skin evaporation, sometimes from feces, urine. So there is always some insensible losses that we always add, and that usually we add as extra 500 ml. So how much it will be then? So 2 liter, 7 and 5, 1200, then another 5, 1700. So 2 liter plus 1700, about 3700. Make it as a whole, which means 4 liter, right? So 2 liter, 4 liter. So input is 2 liter, output 4 liter. So how much patient is having deficit? 2 liter. So obviously you need to give extra 2 liter to this patient. Is this clear until now, guys? This input-output measurement? Good. All right. Now, when you want to do this fluid balance in a patient like this, the basic fluid balance or maintenance fluid that we give is every patient in the post-operative day, they will get 1 liter normal saline plus 2 liter dextrose. Plus, when it becomes post-op day 2 plus, then also we give some potassium to this patient. So that potassium is 20 milliequivalent of potassium per liter of fluid. So every liter of fluid that you are giving, with that you add 20 ml of potassium. So 1 liter normal saline, 2 liter dextrose, and 20 milliequivalent of potassium per liter of fluid. So now this is maintenance fluid for everyone, but this patient is having a deficit of 2 liters. So you have to add this 2 liter to this existing maintenance fluid. So normally we give this 2 liter by adding with the normal saline. So if you add 2 liter with the previous 1 liter normal saline, it becomes 3 liter normal saline, 2 liter dextrose. Now, how much will be potassium? So 20 into how much fluid you are giving to the patient. 3 plus 2, 5. So 5. So that equals to 5 into 20 means 100. So that will be your 100 milliequivalent of potassium. So 3 liter normal saline, 2 liter dextrose plus 100 potassium. That is your fluid maintenance in this patient. If you come to the option, you will find it here. Number D, 3 liter normal saline, 2 liter dextrose, and 100 milliequivalent of potassium. All right, so that's your fluid balance in your post-operative day. Any question, guys? Did you understand that how we came up with this option D in the question? So what's the confusion, Dr. Munmun and Dr. Abdullah? Potassium part, yes, obviously we can recall it again. So the thing with the potassium is that every liter of fluid that you are giving to the patient, you have to multiply it with 20. So 20 milliequivalent of potassium per liter of fluid. So how much fluid you are giving to the patient? 3 and 2. That means 5 liter. So 5 liter fluid, it will be multiplied by 20. So 20 into 5 equal to 100 liter of fluid. This calculation is mainly for second postoperative day onwards, because in first postoperative day or the day of the surgery, normally we don't need to give any potassium to a patient because already because of surgical trauma and everything, body will release some potassium. So we normally don't offer any potassium in the first day of surgery. After first day of surgery, usually potassium replacement is necessary. So how do we get 3 liter, right? So that is the part you first need to understand that, okay, let's go to the back again. So how much is the deficit of this patient? Two liter, right, Dr. Abdullah? So you need to give extra 2 liter to the patient. Now, in any patient, this is the fluid that we normally offer to every patient. 1 liter normal saline, 2 liter dextrose, and 20 milli equivalent potassium per liter of fluid. So that's you are already giving to any patient. But for this patient, he needs extra 2 liter. So that 2 liter will be added to the normal saline. So previously, patient was taking 1 liter. Now you will add this 2 liter to this existing 1 liter. So it becomes 3 liter normal saline. And other things are same. Is this clear now, guys? Dr. Munmun, Dr. Abdullah, great. And Dr. Ratan, I believe that question should not give you 50 milli equivalent of potassium in this question. It should be 100 milli equivalent. Yeah, in the group, there is a lot of thing happens. Don't waste a lot of time on the group questions because this is very hard for anyone to even remember what can come up in the exam. So that's fine. You just need to know what is the correct formula of fluid balance. And obviously in the exam, you will find out the correct one. Yes, input output should be same, but in this patient, already patient has lost. So you are giving that deficit amount for the moment now. So eventually input output will become same. No, this is not for the question. Potassium calculation is for as a standard. All right, so that was all about that fluid balance chart. A lot of like in a lot of ways this can appear in the exam. It's not like that this will come, but you just need to make sure that you know how to calculate the potassium, how to calculate the deficit amount, and how we normally go for this imbalance or how we correct this imbalance. Next question. So patient comes back from Thailand with history of having sex with multiple prostitutes. After 1 week, presents with lymphadenopathy, mild pharyngeal erythema, splenomegaly, sore throat. You have also got atypical lymphocytes. Monospot test is negative. What is your diagnosis? HIV, Epstein-Barr virus, CMV, Hep A, or Ross River fever. So by looking at the question, what is your first thing that comes in your head? Like having a sex with multiple prostitute, you HIV, right? Now that's the trap. Remember, I told you initially that something which is very evident in a question, and even it's in the top part of the question, most likely that's not your answer, because that's a trap that is given by the examiner, so that you don't even look at the option, you don't even read the other things in the question, and you end up just selecting HIV as your answer. And that's the trap I was talking about. What is the other trap? We know that in Epstein-Barr virus, monospot test is positive, just like Dr. Jainav has said right now. So, but the question is, monospot test, is it a specific test for Epstein-Barr virus? No, because it only gets positive in 60% cases, maybe, or even less than 60%. So how about that extra 50 to 40% people whose monospot test is negative, even though they have Epstein-Barr virus infection? So you can't just rule out Epstein-Barr virus based on the monospot test, because that is not a specific test for Epstein-Barr virus. Many patients can get positive monospot if they get Epstein-Barr virus, but it doesn't mean you can rule out Epstein-Barr virus if monospot comes negative. Now, so especially when a patient has this kind of symptom, let's say history of going to Thailand doesn't always mean that it has to be HIV. It can be any viral infection. Now, the symptom is important. So patient presented to you with lymphadenopathy, pharyngeal erythema, which means patient might have sore throat, which already we know, splenomegaly, atypical lymphocytes present. Now let's move on to this clinical feature to differentiate various viral infection. So in our option, we have got Epstein-Barr virus, HIV, CMV. CMV is not very common in your exam question to come, so don't bother too much about it. But Epstein-Barr virus and HIV, both of them, fever can be a possibility. Fatigue, common in both. Tonsillar hypertrophy. It is very common to get pharyngitis, sore throat, tonsillar enlargement in Epstein-Barr virus infection, whereas having a sore throat, pharyngeal erythema, those are very rare in HIV. So having sore throat usually gives you the diagnosis of Epstein-Barr virus rather than HIV. So that's one thing that we have got from here. Whereas having an oral ulcer or ulcer anywhere in the body, it is very common in HIV. Jaundice can be found in Epstein-Barr virus, rare in HIV. Hepatomegaly, splenomegaly can be found in Epstein-Barr virus. Even splenomegaly, about 50% cases, you can find in Epstein-Barr virus infection, whereas it is very rare in HIV. Now, this is also one of your findings in your question. Atypical lymphocyte can be found in both cases, whereas in Epstein-Barr virus, it is 80 to 90%, less than 50% in HIV. Lymphadenopathy, especially cervical lymphadenopathy, common in both. Now, having a read of this clinical feature from John Murtagh, what do you think is your diagnosis? HIV, Epstein-Barr virus, CMV, Hep A, Ross River. In the exam question, if you are not sure about a particular thing, always use the exclusion method. So what is the exclusion method? Hepatitis A is very unlikely in here because there is no jaundice. So hepatitis A is out of the question. How about Ross River fever? Always remember, Ross River fever patient gives you a history of traveling to northern Queensland. And also like they had some bushwalking camping, and they end up getting a mosquito bite in here. And that mosquito bite causes this RRV or RRF, which is a Ross River fever. In Ross River fever, patient present to you with fatigue, tiredness, generalized malaise, and a very typical maculopapular rash all over the body. They also get lymphadenopathy, like a generalized lymphadenopathy, and they get arthralgia, lots of muscle aches and pains. So you will not get sore throat, splenomegaly in this patient. So that's Ross River fever. Cytomegalovirus, not common in a healthy individual. It is common in organ transplant and also like patients who are very immunocompromised. Okay, but in case of CMV, also tonsillar hypertrophy is uncommon. Splenomegaly can be there. Cervical lymphadenopathy is uncommon. So our patient has lymphadenopathy, splenomegaly, sore throat. So CMV is also unlikely. Between HIV and EBV, that's where we are confused. And actually in exam, you will always be confused between two specific options. So you have to be very careful between that two, which one you are going to choose. So how we rule out HIV here? By having these features of pharyngeal erythema, sore throat, and splenomegaly, which are not very common in HIV, rather it is very common in EBV. So that's why Epstein-Barr virus will be our answer. What is the other name of Epstein-Barr virus infection? Infectious mononucleosis, or there is another name, glandular fever. Okay, so that's all about this question. Any question, anything that you did not understand? See that how we are learning, so that is exactly how you should do it. Because now you know the features of 3 viral infection, not 3, even 4, because you also know Ross River fever now. So that's how you learn. With the questions, you learn the topic. You just don't learn the answer of the question. Okay. Next, man coming back after short trip from endemic area for only 5 days with severe jaundice. Patient also having fever. On examination, you found tender hepatomegaly. You also found very high ALT, AST, GGT, ALP. What is your most likely diagnosis? Acute viral hepatitis A, hepatitis B, malaria, infectious mononucleosis, or choledocholithiasis, which means a stone in the bile duct. Obviously, a stone in the bile duct is not very likely in here, because in a CBD stone, if it causes cholangitis, then you can get fever, jaundice, and right-sided upper quadrant pain. There is no right-sided upper quadrant pain in here, so let's not think about cholangitis or choledocholithiasis in this case. Infectious mononucleosis is not commonly will give you a tender hepatomegaly, so always think in the exam which one is common. Then we have Hep A, Hep B, and malaria. Having a history of trip, usually we think about Hep A rather than Hep B. So let's not think about Hep B just for the moment. It can be, so we might come to this one, but let's just not think about it because of the history of a trip. Because travel history most of the time gives a possibility of hepatitis A because of fecal-oral transmission. How about malaria? Now, malaria can give you this kind of symptom, especially malaria patient can have fever. Malaria patient can get mild jaundice, but they don't get a severe jaundice. And malaria does not give you a tender hepatomegaly, especially acute malaria does not give hepatomegaly. Chronic malaria sometimes can give hepatosplenomegaly. So obviously, if it was malaria, which is not very common to present within 5 days, but still, if it is a Plasmodium falciparum, it can be, but in acute malaria, we normally don't get a severe jaundice with a tender hepatomegaly. So that's why we are not thinking about malaria in here. Yeah, so malaria needs a longer incubation period, right? Acute viral hepatitis A, that is the most likely cause because of a lot of things. So patient having fever, having severe jaundice, that means most likely patient is at the moment in a icteric phase of hepatitis A. And on the top of that, the investigations are also important. See, the ALT, AST is high. That's usually happens in hepatitis A or B. And also tender hepatomegaly is one of the feature of hepatitis. So all of this goes with hepatitis rather than malaria or any other option. Same question, if patient went to Thailand, had a multiple sexual intercourse with multiple prostitute, we would think about hepatitis B here. Because hepatitis B is supposed to get transmitted with a sexual contact. So it always depends on what question asks you and what is the tips given. In here, your tip is this short trip from the endemic area. That is your main tip in here to get into this hepatitis A as your answer. So hepatitis A comes with this prodromal phase first, which means initially anorexia, nausea, vomiting, malaise, sometimes distaste for any food, sometimes upper abdominal discomfort. And then after a few days, they go into icteric phase where they develop jaundice, dark urine, pale stool, and then they go into the recovery phase. If you get tender hepatomegaly in a question, think about possibility of viral hepatitis, congestive cardiac failure, liver abscess. These are the three most common causes of tender hepatomegaly. If you look at this table, which is your liver function test, sometimes this will help you to find out the cause as well. Obviously, if a patient having jaundice, bilirubin will be high, but that does not help you to differentiate between hepatocellular jaundice, obstructive jaundice, or hemolytic jaundice. The main thing is viral hepatitis present as a hepatocellular hepatitis. That means it infects the cells or hepatocytes. So in those cases, your main finding will be ALT, which is your alanine transferase, that will be elevated even more than 5 times of normal. So ALT will be mainly elevated in hepatocellular jaundice. With that, AST can be elevated. AST mainly elevated in alcoholic patient. Same with GGT, mainly elevated in alcoholic patient. Alkaline phosphatase, if it is elevated more than 2 times of normal, that is suggesting of obstructive jaundice. So mainly you look at these features. If ALT is mainly elevated, that's hepatocellular. If AST, GGT mainly elevated, most likely alcohol related. If ALP or alkaline phosphatase is elevated, most likely it's a obstructive jaundice. Okay, so that gives you a fairly good idea about this question. Any confusion, guys? Great. You guys are doing very good. Scenario of a patient with a fall from the bicycle 1 week ago and also had a helmet fracture. No confusion, no amnesia, but patient has headache which increases with coughing. What does this mean? Headache which gets increased with coughing. What is the most likely diagnosis? Right? So what do you think that which causes symptoms like this? Headache which get to increase with coughing, bending forward, raised ICP. Okay, if someone have got a raised intracranial pressure, that can give this headache. So something is obviously in the brain which is increasing this pressure. So either it's the blood or maybe something else. So now the question is, patient had a bicycle fall and it was really severe enough to cause helmet fracture. And patient had no confusion, no amnesia, just features of headache. So you want to think about intracranial hemorrhage. Always remember, if it is intracranial hemorrhage, patient would not be like this for 1 week. Patient would be really, really bad within a week. So intracranial hemorrhage should come within hours. How about subarachnoid hemorrhage? Patient would not tolerate it for 1 week. Subarachnoid hemorrhage, the pain severity is 10/10. So patient will come to you within hours. How about extradural hemorrhage or epidural hematoma, subdural hematoma, or concussion? We can't say concussion without ruling out possibility of this epidural or subdural hematoma. And in concussion, patient usually get little bit of amnesia features as well. So let's not think about concussion only when a patient having a raised ICP, because raised ICP means something is there. It's not just a hit in the brain and now the patient having a concussion. So something is obviously inside the brain, and that's most likely a blood which is causing it. Now, it's not intracranial, so what it is? Either it's a epidural or subdural. Now, the question is how we differentiate between these two. There is a basic difference that if you get a patient who has got epidural hematoma, in case of epidural hematoma, the helmet will not fracture. That's the main thing, that epidural hematoma, the hit will not be that much severe, because obviously epidural means it's the top layer of your dura mater, right? So that's epidural and then subdural. So obviously, which one needs, like if there is a helmet fracture, then obviously that was really a bad hit. So will the top layer will be broken or the next layer? What is the chance? Chances of having a fracture or having an injury in the next layer is much higher than just this upper layer, right? So if it always depends on the force of the injury or trauma. If the force is high enough that even can break the helmet, it's very unlikely it's just an epidural hematoma. On the top of that, epidural hematoma patient gives a typical feature where they first get confused, loss of consciousness, then they wake up and totally fine, and then they again fall into a total loss of consciousness. That feature is a typical of epidural hematoma. Whereas subdural hematoma, it takes some time to present. So the basic find, yes, the lucid interval, which is mainly found in epidural hematoma, right? Now, the two things that you need to find out in your stem when you are trying to exclude epidural or subdural, what is the force of trauma? Is it very high? Then we go for subdural. If it is if there was no helmet fracture, we might think about epidural hematoma only. The next thing is, what is the presentation? Did the patient had a loss of consciousness and then became totally fine? If that is the case, epidural. If patient did not lose consciousness, it's been a week, but it's still no problem, but only there is headache, we would rather think about subdural hematoma. Okay, so that's how we differentiate between these two. So subdural hematoma or epidural hematoma, how we find out in your CT scan. In subdural hematoma, the CT scan will show there will be a crescentic shape of blood collection. Obviously, in a CT scan, blood looks whitish. So this whitish area that you can see, that's the blood. So if it's a crescent-shaped blood collection, that's subdural. If it's a biconvex shaped, that is your epidural hematoma. Okay, so that's how we differentiate these two things. It is very hard to differentiate in the exam as well. So please make sure the discussion that we just had now. Next. Now this will be an interesting discussion, genetics. Parents came to you that their son has hereditary spherocytosis. So what is the mode of inheritance of hereditary spherocytosis? Is it an autosomal dominant? Is it autosomal recessive? Is it X-linked recessive? What it is? That's what you need to know first. They want to know that what is the chance that his siblings will also get the same disease. So he already has got this hereditary spherocytosis, and now the parents want to know that what is the chance in his siblings. So first thing first, it is autosomal dominant. Very good, Dr. Jara. So autosomal dominant, how we know the mode of inheritance in an autosomal dominant pattern. So let's discuss that first. Now, try to understand it, because this discussion will help you a lot for a lot of questions in your exam. Now, for the purpose of your understanding, I will keep male as XY and female as XX. But in case of autosomal dominant or autosomal inheritance, we actually don't need to put XY or XX. Only for X-linked recessive pattern, we usually put this XY, XX. But because XY, we all know it's male, and XX, it's female, so we will just follow that part. But it doesn't mean that this is an X-linked pattern. It's just a symbol for a male and female. Just remember in that way. And any of them can be dominant in here. It doesn't mean that in here the Y will have to be dominant. Any of this gene can be dominant gene. So let's say in this patient, this Y has the defect gene. Or let's say father had hereditary spherocytosis, and this Y gene was the defective gene. Now, what is the possibility of their offsprings? So it can be X and X. It can be another X and X. It can be XY prime. And it can be another X and Y prime. Right? So these are the two sons, and these are the two daughters. So in each pregnancy, these are the possible combination. Now, if you look at here, in a autosomal dominant inheritance, only one defective gene is sufficient to transmit the full disease. Okay? So obviously, this child will get the full-blown disease. So he is diseased. Same with this child, he will be also diseased. This one doesn't have any defective gene, so healthy. This one is also healthy. So 50% is totally normal, and 50% will be diseased. So that's how the autosomal dominant inheritance happens. And this 50% disease can be anyone, can be son, can be daughter. It does not have any gender, like X-linked recessive pattern. So it can be son or daughter, both. Now, if you see here, it is an autosomal dominant inheritance. So what will be the chance in the siblings? Always remember, in each pregnancy, this pattern will be always same, 50%, 50%. So 25% of his brother, 50% of his sister, 50% of his brother, 0% of his brother, sister, 50% of his brothers and sisters. So 50% of his brothers and sisters has the chance to get the same disease in each pregnancy. Always remember, it doesn't mean that one son has already got the condition. So that means from 50%, 25% is already diseased, then only 25% will be diseased again. It doesn't mean that. A lot of people has this misconception. So it's in each pregnancy, 50% of his brothers and sisters can get the disease, and 50% of his brothers and sisters might be totally healthy. So that's autosomal dominant inheritance. Now let's discuss a little bit more complicated one. Now let's say we come to the autosomal recessive inheritance. What happens in autosomal recessive? So let's say again the same XY and XX. Let's say this is a thalassemia minor father who married a thalassemia minor mother or thalassemia minor wife. Okay, so we have got a thalassemia minor who married and now having kids. So what's the problem with that? Let's say in thalassemia minor, so this one is the defective gene. This one is the defective gene. Because it's autosomal recessive, to be full-blown disease, there needs two defective gene in a one person. It's not like autosomal dominant in which you just need one defective gene. So to be the full-blown disease, you need two defective genes. So that's why they are carrier, because there only one gene is affected, other is fine. Okay. Now, what are the chances? So we have got X prime, X prime. We have got X and X prime. Then we have got X prime Y. And we have got XY. Right? So, what do you think that they are having at the moment? So tell me, like, what do you understand by this? That means this one, X prime, she has got two defective genes. That means this 25% is most likely like got a full-blown disease, or it's an active disease, or thalassemia major. X prime 1, they have got one defective gene. So this 50%, they are carrier. And the other 25% is healthy. So chances of having thalassemia. Now the question will be like this: what is the chances of having a thalassemia major in this patient? So thalassemia major chance is 25%. Chances of having a carrier of thalassemia is 50% and healthy 25%. So that's how you find out. Now the scenario might be totally different if one thalassemia minor patient married just a healthy patient. So then the scenario will be different. So you don't need to memorize this thing. You just use your knowledge and basic to find out what could be the answer in your exam. Is this clear, guys? A lot of people has difficulty understanding this, but now it should be clear. So that's all about your autosomal recessive and autosomal dominant. We can say in autosomal, X and Y doesn't matter. Any gene can be defective. Okay, Dr. Ratan, it's not about X and Y in autosomal. Any gene can be affected. It doesn't matter. And also in autosomal, anyone can get disease. The daughters, the son, anyone. So that's why X and Y is not it doesn't matter here. So if you just give like Y as defective gene, just it will be a different pattern. So it's totally fine. Anything can happen. And in case of autosomal dominant or autosomal recessive, you can also use like A, and then B and B. So that's also the thing. So you can put this B as defective also. So it doesn't matter at all. It's not about XY in an autosomal inheritance pattern. All good. Any question, guys? Next question. A lady comes to you with weakness of lower limbs. She drags her foot while walking. Dorsiflexion and plantar flexion is weak, but reflexes are exaggerated with an equivocal plantar response. What is the diagnosis? Tricky, right? So patient coming to you with a weakness of lower limb. So both lower limb having weakness. She drags her foot while walking. So obviously because of weakness. Now dorsiflexion and plantar flexion is weak. So that's we understand because of weakness this is happening. Now, when that is happening in the both limbs, and also in the both limbs, now reflex is exaggerated. So it's a hyperactive reflex, but the plantar response is equivocal. So are we thinking about cervical spine MS, motor neuron disease, spinal canal stenosis, or lesion in the cervical cortex? The question is a little bit of tricky. If they ask you diagnosis, better not to just say that it's a lesion in the cerebral cortex, because what does it call? If the question was like this, that where is the lesion most likely, or what do you think that what is the most likely lesion of this patient? If they ask that what is the most likely cause of his presentation? So if that is the thing, then we could think about cerebral cortex lesion, but they're asking about diagnosis. So what is the diagnosis in here? The main thing is that if you get a patient who has both upper and lower motor neuron type of feature in their limbs, that is what we call as motor neuron disease. Now, it is not very common to get a motor neuron disease in a female, but still, there is no other choice which will go in favor with this type of question. I will come to the discussion how we can rule out other things. Let's say that it is a case of cervical spine MS, multiple sclerosis. If it was the cervical spine involved, where you should get weakness first? In your upper limb, right? So your upper limb should have some symptom. It should not be only on your lower limb. So that's how you just remove cervical disc from your option. How about spinal canal stenosis? Spinal canal stenosis gives you a upper motor neuron type of palsy always. You will never get any lower motor neuron type of palsy below the lesion. So spinal canal stenosis, you could think about it if the patient showed spastic paraplegia, then hyperreflexia, the plantar is extensor. If that was your finding, then you could think about spinal canal stenosis. But in this patient having both upper motor and lower motor neuron type of feature. How? This equivocal plantar response, that is most likely lower motor neuron. Weakness like this, lower motor neuron. Whereas reflexes are exaggerated, that's mainly upper motor neuron. Okay, so that's how we think about that it is not just upper motor neuron type of palsy. So that's why we are ruling that out. Now, between motor neuron disease and lesion in the cerebral cortex, I would rather choose motor neuron disease because that's a diagnosis. Lesion in the cerebral cortex is not a diagnosis. Okay, so obviously motor neuron disease, it's a kind of lesion in the cerebral cortex, but it's not lesion in the whole cerebral cortex. Only the motor neurons in your cerebral cortex will be affected in motor neuron disease. So that's why I'm not going into the lesion in cerebral cortex, rather sticking to the motor neuron disease in here. The basic is that there are a lot of types of MND. Sometimes patient can get just lower motor neuron type of palsy, just upper motor neuron type of palsy, or a combination of upper motor and lower motor neuron type of palsy. So this patient most likely has got the commonest one, which is the combination of upper motor and lower motor neuron. Okay. So look for those kind of feature. If you get a patient who is having both upper motor and lower motor neuron type of feature in their limbs, we would rather think about motor neuron disease always. Now, if sometimes they can ask you that what will be your next investigation in this case. So if you're thinking someone to have a MND, what is your most appropriate next investigation? So in exam, time to time, you will end up getting this kind of question, most appropriate next. If question asks what is the most appropriate next, that means your initial investigation. If question asks what is your most appropriate investigation for this patient, and that means that they are asking about the definitive one. So whenever next is there, means initial. So in an MND patient, the initial investigation that we do is the MRI of brain and spinal cord, because MRI cannot confirm it, but it can rule out a lot of other conditions which can have similar presentation, just like MND. So that's the reason of doing a MRI as initial. What is your most appropriate investigation? Sometimes in these cases, we just do a electromyogram or nerve conduction study to confirm the diagnosis. So either we go for EMG, electromyogram, or nerve conduction study. All right, so that's your motor neuron disease. These are very, very important, complicated questions. And these things are the typical of exam question. Okay. Now, let's go to the next question. 58-year-old man dragging his left foot. Reflexes on the left lower limb are increased. Plantar flexion and dorsiflexion are weak. Weak ankle movement, equivocal plantar reflex, upper limb and face are normal. What is the site of lesion? Now, there is the question, right? They're asking now, where is the lesion? Common peroneal nerve, cervical spinal cord, L5S1 nerve root, cerebral cortex, or brainstem. Now, obviously, this is a lot to discuss. Let me give you some clue, and you will always be able to rule out these things based on that clues. Common peroneal nerve, it's a nerve which is like a distal nerve, you can say. And that nerve mainly supplies your anterior portion of the leg and dorsum of the foot. And any nerve which is like a distal nerve, it will never ever affect your reflex. So you will never get increased reflex when the distal nerve is involved. So when you got reflexes are increased, immediately you forget about common peroneal nerve. Okay? Then you come to the cervical spinal cord. Again, if it is a cervical spinal cord, the feature should be on the upper limb. How about L5S1 nerve root? Now, nerve root problem can cause increased reflexes or decreased reflexes. But the good thing is that L5 does not give any reflex. And also, L5 does not help with plantar flexion. So if you see here, plantar flexion is weak. That is not the job of L5. And most importantly, L5S1 nerve root would not give you any equivocal plantar reflex, and your plantar flexion will not be involved in these cases, because L5S1 mainly helps with your dorsiflexion of the foot, and that's all. It doesn't affect with any reflex. It does not deal with anything else. So when reflex is exaggerated, we don't think about L5S1 nerve root, because L5 does not have any reflex. L3, L4 gives you the knee jerk. S1, S2 give you the ankle jerk. So what is in the middle? L5. So that's why when L5 is involved, we don't expect that reflexes will be exaggerated or reduced. How about brainstem? If brainstem is involved, you will get the features of brainstem involvement. What are those? You will get, patient will come to you with dysphagia. They will come to you with a swallowing difficulty. They will come to you with nystagmus. They will have vertigo. Okay? They will have problem with their voice. So those are the features of brainstem involvement. None of them are here. So only thing, even with exclusion, only thing remains is your cerebral cortex. And we already know that this patient has got both upper motor and lower motor type of feature in their leg. Reflex increased, but plantar reflex is equivocal and weakness in the distal muscles. So that means this patient having motor neuron disease. And motor neuron disease means when the motor neurons in your brain spinal cord, everywhere, when the motor neuron is affected, that is what we call as motor neuron disease. In motor neuron disease, no sensory loss will be there. That is the trick. So if there is a loss of sensation, it's not motor neuron disease. Now you're thinking that if there is a loss of, or if there is a lesion in the brain cortex or cerebral cortex, why the patient only having trouble in the foot or in the lower leg? Why not in the upper limb? The reason is this homunculus. Let's say, see that this is your cerebral cortex. Some part of your cerebral cortex help with your upper limb, some part with your face, some part with your leg. Now, obviously, this patient has got some kind of like a motor neuron problem in this part of the cerebral cortex. That's why only the lower limb is affected, not anywhere else. Okay? Is this clear, guys? I know that this is a little tricky to get and very confusing, but I hope that you understand it now. All right. Now, let me take a 5-minute break, and then we will start with how to do the CVD risk assessment. Okay. I know that your brain is now pounding, so let's just give the brain a little bit of time to reboot itself. So 5-minute break. Thank you. All right, so let's start again, guys. So now we are going to discuss about the CVD risk assessment. So normally for CVD risk assessment, they will give you all the information that you need for this risk assessment, and they give you this kind of a graph. And you can see that there is a lot of color in here. Everything has a meaning for it. Now you have got a 64-year-old, and let's say this is a male patient, smoker. Oh, sorry, it's a woman. So 64-year-old smoker women with blood pressure 135/68, cholesterol HDL ratio 6.6/1. The chart is given. What is her 5-yearly CVD risk? So in case of a CVD risk assessment, you need the information that what is the gender of the patient? Is it a man or woman? You need to know that is this patient having a diabetes or not? As you can see in the top part, it's for people without diabetes. So obviously she is not diabetic, so we will use this chart. In the exam, maybe there will be some other chart where patient has diabetes. So you have to look for these things in the question. So this is for people without diabetes. This part is for men and this for women. So our patient is a 64-year-old woman. So in here you can see the ages. So 64 means this one is our patient's age. Then we have a smoker and non-smoker. So our patient is a smoker. So obviously we are mainly focusing on this part of the graph. So first thing first, you need to find out where you are looking. So now we know we are not looking anywhere else, but only this portion. Then on the y-axis, you can see that in here your systolic blood pressure, and in the x-axis we have cholesterol HDL ratio. So that's information in here given. So systolic blood pressure is 135, and we know the cholesterol HDL ratio is 6.6/1. Now, you have to see that where you can plot this patient. So let's say, first of all, you can see in here 120, 140, 160, 179, right? The main thing that you need to understand, same in here also, this is for ages of 55, 64. The main thing you need to find out that this is one box. You can say the left lower box. The main thing you need to remember that what is the maximum number you can put in this particular box. So the maximum number in here is up to 130. So it's not about 120. So don't get confused by that. That is the confusing part in this chart, that the maximum number in here is 130. What is the maximum number of this box? 150. This one, 170. So that's how you remember it. Now, always, if someone has got the marginal one, if someone's blood pressure is 130, which means in the marginal part, you always choose the next one. That means you will choose this one. Is this clear for everyone? So this one, this box, the maximum number is, you can say, up to 129. Okay. For this one, maximum is 149. This one, maximum is 169. Now, if we know about it, our patient's systolic blood pressure is 135. So which box the patient's systolic blood pressure will fall? So we know that this one means up to 130 or up to 129. This one is up to 150. So obviously, our patient's systolic blood pressure falls in this row, right? The next thing you need to find out, what is the total cholesterol HDL ratio? The total cholesterol HDL ratio in my patient is 6.6 by 1. Now have a look at here. We have got 4, 5, 6, 7, 8. Again, what is the maximum number we can put in this box? 4.5, not 4. So the maximum number will be 4.5. Here 5.5. This box 6.5, 7.5, 8.5. Now our patient is 6.6. So where we will put her? So 6.6 means up to this is 6.5, right? Then 6.6 means in this particular box. Now we know that we are mainly looking on this box. So our patients, we will have this box, so we'll just go up, go up, go up, up, up. So this yellow one is the main point that you are looking for. So all of you know how to plot this kind of things in a graph, right? So this is how we plot graphs. So you need to find out your x-axis and y-axis and then just find out the point that you're looking for. Is this clear, guys? I understand that many of you have never seen this chart before. But is this clear? Now, what does this yellow red things mean? In the exam, they will give you that the red means patient having a 15 to 30% risk of having a CVD or cardiovascular condition in the next 5 years. Yellow means maybe 10%. So that will be given in your question, and the question will just ask you what is the percentage of CVD risk in this patient. It is a lot of time, but it gives you a lot of mark in the exam. Okay, so something which is hard to do, but if you can do it, there is a high chance that these questions carry more mark than others. Now let's say I have given you a case. You have got a 55-year-old, or let's say 50-year-old male who is a smoker. Systolic blood pressure is 130 by 80, and cholesterol HDL ratio is 6.5 by 1, and no diabetes. What do you think will be your answer? So that nominators for the color will be given in your question. I will show you the link that where we can get it. So let's do this one. So we have got a man. So this one, we have got a smoker, this one. We have got a 50-year-old, which means we are looking for this particular box. Now find out the X and Y axis. Systolic blood pressure 130. So we know that 130 means, we know that up to 130 we can put in this box. But because 130 is the marginal, we will choose the second box. That means this box will be our chosen box, right? This one. Let's find out the y-axis, 6.5. So we know that this is 4.5, this is 5.5, this is 6.5. Now 6.5 means marginal. When it is marginal, we go to the next box. So this box is our main box. So we are going up, up, up. So this is the patient color. green, sorry, blue. Okay, so blue is our color for this patient. Is this clear? Yeah, I can see that many of you has done it correctly. Very good. Now, how we know the, like which color means what? This is your Australian guideline. If you go there, you will find it out. So this is the guideline of Australian cardiovascular risk chart, the same chart that we are doing. And that's what it means. See that red means more than 30%, blue means 10 to 15%, and the green means low risk, 5 to 9%. So this color will be given, you don't need to memorize it. So that's your CVD risk assessment, very important for the exam. Okay. Now, another nerve entrapment question. Always remember, nerve-related questions carries high mark in the exam because these are hard. And if you can ace these kind of questions, high marks. The patient illustrated has presented after sustaining a stab wound to the back of the left forearm in a so most likely this arm, right? So this forearm, the patient has got a stab wound. He's trying to straighten his fingers on command. The right hand, you can see patient is able to do the straightening, but left hand, patient is not able to do extension of the finger, but extension of the wrist joint is fine. Which of the following nerve is most likely to have been injured? Median nerve, ulnar nerve, radial nerve, posterior interosseous nerve, anterior interosseous nerve. Now, to understand this kind of question, you have to have a fairly good knowledge about all nerves of the hand. But let me give you one very easy things that you can immediately rule out A and B. Always remember the dorsum of your hand. This is the dorsum. Dorsum of your hand is supplied by your radial nerve only. And a little bit will be supplied by ulnar nerve, but that's this little finger and the lateral of the ring finger. But most of the dorsal of the hand will be supplied by your radial nerve. Median and ulnar nerve gives you the main sensation or main function of the palmar aspect. So anything in the palmar aspect, think about median or ulnar nerve. Anything on the dorsal aspect, think about radial nerve. Now still, it's not the radial nerve is your answer. We have more than that. You will find out why in the exam you have to be very accurate. Now let's go on. So what is the radial nerve anatomy? So all of us know that radial nerve starts from your brachial plexus. From here, it goes down from the back of the radial groove of humerus. Then it comes forward at the elbow joint and then divides into two branches. One is called posterior interosseous nerve and another is superficial radial nerve. That means posterior interosseous nerve is a branch of radial nerve. Okay. Now, how we know radial nerve injury and what kind of presentation it will give. So depending on where it actually got injured, the presentation will be different. Because radial nerve can be injured anywhere, starting from the axillary region down to the wrist, anywhere radial nerve can be injured. So you need to know that what kind of presentation you can get based on the area of injury. So if the injury happens at the axillary region, what will happen to the motor and sensory? Remember that radial nerve gives your extension of everything. So extension of your forearm. So forearm extension will be done by your radial nerve. Supination is done by radial nerve, and also extension of the wrist and finger is done by the radial nerve. Now, obviously, if the injury happens in here, everything will be lost. So loss of extension of the forearm, loss of extension of the wrist, loss of extension of the finger. And sensory, radial nerve supplies 3.5 fingers on the dorsal aspect of the hand. So there is your dorsal aspect. It gives supply to your thumb, index finger. Now this one is not right actually, this is wrong. So thumb, index finger, middle finger, and half of the radial finger, or half of the ring finger. So 3.5. So this is 1, 2, 3.5. So 3.5 fingers are supplied by the radial nerve. The other part will be supplied by the ulnar nerve. Okay, so in case of radial nerve injury, there will be loss of sensation in this part, like 3.5 fingers, and also because obviously it's carrying sensation from your axilla, there will be loss of some sensation on the forearm as well. So loss of sensation in the lateral arm, forearm, and then 3.5 fingers. So that's what you are going to get if there is an injury in the axillary region. How about if the injury happens in the mid part of the arm? That means if a patient has got a fracture of the humerus, let's say this part has got the fracture, what will be your presentation? So if there is a fracture of the radial groove or shaft of the humerus, then radial nerve can be injured. So in that case, everything will be same, just like in axillary injury, only difference will be sensory loss. In this case, loss of sensation will be only in the fingers, but not in the forearm or arm. So that's the only difference between the axilla and the mid-arm injury. How about if the injury happens just below the elbow? Let's say around here. Okay. In that case, the motor deficit just below the elbow usually injure the posterior interosseous nerve. So if posterior interosseous nerve injured, it is an entirely motor nerve. It does not give any sensation. So that means there will be no sensory loss. Only thing will be motor loss. And what kind of motor function does this posterior interosseous nerve? It only helps with finger extension. Okay, so if a patient has got below elbow injury, the injury will be on the posterior interosseous nerve, and only loss of problem will be loss of finger extension, which actually happened to our patient. As you can see, there is no loss of sensation given. Only thing is loss of extension of the finger. So that's most likely that because patient has got a forearm stab, that's a below elbow injury, most likely that is the reason that why this patient is not able to extend the finger. How about if injury happens around the wrist joint, like distal forearm? In that case, superficial radial nerve will be injured, which is entirely sensory. And only finding will be loss of sensory function in the radial dermatomal area. Okay, so to give you a summary, look at this picture again. If a patient has got injury at the axilla, there will be loss of extension of the forearm, loss of extension of the wrist and finger, loss of sensation on the little bit on the arm, then on the forearm, and also 3.5 fingers. If the injury happens here, that means the mid shaft of the humerus, everything is same. Only thing is there will be no loss of sensation in the arm or forearm, but others are same like axillary injury. What if below elbow injury. Below elbow injury usually affect the posterior interosseous nerve, which is entirely motor, and patient will have loss of extension of the fingers only. If there is injury to the distal forearm or around the wrist, only nerve which is injured is the superficial radial nerve, which is entirely sensory. And your finding will be loss of sensation on these 3.5 fingers. Okay, clear, guys? So now your answer is posterior interosseous nerve, right? What is the branch? Like anterior interosseous nerve. It's a branch of your median nerve, okay? And posterior interosseous nerve is a branch of radial nerve. So radial nerve is also true, but which one is more appropriate? Posterior interosseous nerve. So in exam, you will get confusion like this, like both answers are correct. Which one to choose? The more appropriate one, okay? Next question. So we are doing a lot of nerve things today, right? I know that this is hard, but trust me, this will clear your knowledge a lot and you will feel confidence in the exam. So we have got a 64-year-old woman who is complaining of dragging her right foot and numbness and paresthesia in that leg. So dragging of the foot. On examination, there is foot drop with weakness of dorsiflexion, inversion, and eversion of the ankle. The reflexes are normal, and there is, sorry, someone's microphone was on, that's fine. So reflexes are normal, and there is loss of appreciation of pinprick, that means loss of sensation on the outer side of the lower leg. Which of the following nerve or nerve root is most likely the cause of her presentation? So this is the lower limb nerve. We have just done the upper limb. Now we are doing the lower limb nerve problem. This is a tricky thing because you have to have a lot of idea about the nerve function of the lower limb to answer these questions. And these questions carry high mark if you can find out in your exam. Now, if you remember your anatomy, then these questions are not very hard. But if you don't remember it, then it can be like, this will be nightmare for you. So let's discuss one by one, and we will come to the conclusion later on. So our patient has got main issue with the foot drop. Foot drop means that patient is not able to raise their foot up. And raising the foot up means dorsiflexion. So obviously this patient has got weakness of dorsiflexion. That's why there is foot drop. Okay. Reflexes are normal. And there is loss of sensation on the outer side of the lower leg. Now you need to first know about the dermatome of the lower leg. So if this is your lower leg, and let's say this is the knee joint, this part is given by lumbar 2. Okay. Then on the anterior portion of your knee joint is done by lumbar 3. Medial side of your leg is given by lumbar 4. Outer side or lateral side of the leg is given by L5. And outer aspect of your dorsum of the foot and the sole is done by S1. Same in here. So this part will be done by the L4. This part is L5. This part is S1. This one is L3. Our patient has loss of sensation on the outer side of the lower leg. And what does it mean? L5, right? Outer side of the lower leg. So our patient having a loss of sensation on L5 dermatom. So we already know that. Keeping that thought in your head, let's move on to common peroneal nerve. So what happens with the common peroneal nerve is that common peroneal nerve start from your lumbosacral plexus. So if this is your hip joint, obviously there is a lot of, like just like your brachial plexus, in your lumbosacral area, there is a lumbosacral plexus from where all this lower leg nerve root comes down. So L1, L2, L3, L4, L5, S1, every nerve root come down from your lumbosacral plexus. All of them, when it connects, it forms a nerve called sciatic nerve. And that sciatic nerve runs from the back of your thigh. So that's your back of your thigh. And then around the head of the fibula, so sciatic nerve running down from your back of the thigh, then divides into two nerves. One is called tibial nerve or posterior tibial nerve, you can say, and another is common peroneal nerve. Tibial nerve goes down at the back of your thigh and then supplies your posterior part of the cuff muscle. That means this part will be supplied by your tibial nerve. This part. And at the head of the fibula, common peroneal nerve will come forward to supply the anterior portion of your leg and the dorsum of your foot. So all this area, this part, will be supplied by your common peroneal nerve. That's why sometimes if there is a neck of fibula injury or fracture, common peroneal nerve can be injured also. Now, common peroneal nerve, when it comes forward, it divides into two branches. One is called superficial peroneal nerve. Another is called deep peroneal nerve. Okay, so let me give you this explanation again so that you remember it for the rest of your life. So from the lumbosacral plexus, sciatic nerve starts to run down from the posterior part of your thigh, divides around this knee joint into two nerves, common peroneal nerve and tibial nerve. Tibial nerve goes backwards, supply the posterior part of your leg. Common peroneal nerve comes front from the head of the fibula and supplies your anterior portion of the leg. It divides into two branches. One is superficial peroneal nerve, another is deep peroneal nerve. So obviously the whole anterior portion of the leg is supplied by your common peroneal nerve. Right? Is this clear up to now, guys? Yes, good, very good. Now, let's come into the function of these nerves. So common peroneal nerve, it helps with eversion of the foot and dorsiflexion of the foot. So eversion and dorsiflexion. Common peroneal has got two branches. One is superficial peroneal, another is deep peroneal. Dorsiflexion done by deep peroneal nerve. You can easily remember D for D. And eversion is done by the superficial peroneal nerve. Okay, so that's the motor function. The sensory function is, you all know that common peroneal nerve will supply the whole anterior portion of the leg. But Now let's talk about superficial and deep peroneal. Superficial peroneal will supply the whole anterior portion of the leg as well as the dorsum of the foot, except for this yellow portion, which is your first interdigital space between the first toe and second toe. This space is the only space which is supplied by the deep peroneal nerve. Okay, so that's your sensory function of common peroneal nerve. Now, look, and obviously remember, if it is a distal nerve or peripheral nerve, it doesn't affect the reflex. Our patient does not have any reflex problem. It could be common peroneal nerve, but the problem is the patient only get loss of sensation on the outer side of the leg. But common peroneal should supply the whole anterior portion of the leg, not just the outer one. So that's how it's not common peroneal. On the top of that, this patient has got dorsiflexion, inversion, and eversion. So common peroneal does not help with inversion. So obviously, this is not a common peroneal nerve. And if it is not common peroneal nerve, then it is not a superficial nerve also. Not also sciatic nerve, because if in case of sciatic nerve, every sensation will be lost, like a whole foot sensation will be lost. And also all the function of the foot will be lost. So it's very unlikely in here. How about the tibial nerve? Tibial nerve, remember, it goes to the posterior cuff and it helps with the plantar flexion, not with the dorsal flexion. So our patient does not have any problem with plantar flexion, so it is unlikely to be tibial nerve. Now we are only left with L4 and L5. We already know from here that this patient has got loss of sensation in the L5 nerve root. If it was L4, the loss of sensation would be on the medial aspect of the leg, and also L4 gives you knee jerk. So knee jerk would be lost also. L5 gives supply to dorsiflexion, inversion, and eversion. That's why our patient having weakness of all these three. Okay, so that is how we know that it is a L5 nerve root problem. In L5 nerve root, motor loss will be dorsiflexion, inversion, eversion. Sensory loss will be outer or lateral side of the lower leg, and there will be no loss of reflex. Okay, so that's the explanation of lower limb nerve root. Any question? All right, so this will be our tonight's last class, last question. So it's a pneumothorax question, very, very important for your exam. So you have got a patient with a 15% pneumothorax in a young person with asthma. Uses salbutamol when has upper respiratory tract infection. Saturation 95, what you want to do. Now, before coming to this question, we will first discuss about pneumothorax management. So all of us know that pneumothorax means that collection of air in the pleural cavity, and that starts to compress your lungs, causing difficulty breathing, chest pain, and also reduced oxygen saturation later on. Pneumothorax has been divided into primary and secondary pneumothorax. Primary spontaneous pneumothorax means that when a patient gets pneumothorax without any underlying lung condition, that's primary spontaneous. That means it just happens without any known reason. The only reason sometimes can happen is that they might have some blips or bulla on their pleural area or lung area, and that can rupture and cause this pneumothorax. but there will be no underlying lung condition in a primary spontaneous pneumothorax. There is secondary pneumothorax where the patient has underlying lung condition or pneumothorax happened after a motor vehicle accident or a trauma. Now, primary spontaneous pneumothorax, based on the size of the pneumothorax and the symptom of the patient, management will be different. What is a small pneumothorax? A small pneumothorax means if it is less than 15% or less than 2 centimeter rim of air in the chest X-ray. Now, you don't need to find it out from a chest X-ray. It will be given in your question that what is the pneumothorax size. So if it is less than 15% or less than 2 centimeter, that is a small pneumothorax. So if it's a small pneumothorax and patient having minimal symptom, then only observation. So you just wait and observe the patient. If patient is doing fine, then after 24 hours, you can discharge the patient. How about large, which means more than 15%, but is still minimal symptom? In that situation, if it is more than equal 15%, then sometimes we offer them oxygen because oxygen can help with the reabsorption of the air that is in the pleural cavity. But only we give oxygen if patient having low oxygen saturation, right? If patient having good saturation, we don't need to offer them oxygen. So oxygen is one thing that we can offer to them just in case patient is having a low saturation. Anything like large or small doesn't matter, but if patient having significant symptom like severe shortness of breath, saturation going down, patient having severe chest pain, that's an indication of doing catheter aspiration or thoracocentesis. So you insert a needle, large bore needle in the second intercostal space. Now, previously we used to do that only in tension pneumothorax, but nowadays this is the first line treatment for significant symptom patient, whether it is tension or not. So catheter aspiration or thoracocentesis, that's your first line. If that doesn't resolve the problem, then you go for chest drain. Okay, so that's your management for primary spontaneous pneumothorax. Let's say you did the catheter aspiration or thoracocentesis. What is the indication of going for chest drain? Obviously, if patient symptom is not resolved, then you can go for it. The other indications are when you inserted the needle, if more than 3 liter air come out, that's the indication. You did a repeat chest X-ray after 2 to 4 hours of aspiration, but it's still more than 15% pneumothorax is there, or patient having significant symptom, that is also an indication of inserting a chest drain. Okay, so these are the indication of chest drain. The next one is secondary pneumothorax, like patient having an underlying lung condition or patient having pneumothorax after a trauma. In that case, you look for what is the age of the patient. So if age is more than 50, if it is more than 15% or rim of air more than 2 centimeter, or patient having significant shortness of breath, any of this happens, you go directly to the chest drain. But none of this, like patient age is less than 50, patient is not having shortness of breath, the rim of air is also less than 2 centimeter. In that case, you can start with aspiration, not improved, then chest drain. Okay? Now come to this question. You have got a 15% pneumothorax in a patient with asthma. First question, is it a secondary or primary pneumothorax? Secondary, because patient have asthma. That's a lung condition. So it's a secondary pneumothorax. Forget about everything in this chart. So think about this one, right? Now, in this case, the question is a little bit of confusing to me, but if you see here, this is a secondary pneumothorax patient. Saturation is fine, 95% is normal. What do you want to do here? You want to aspirate, chest X-ray after 24 hours, chest drain, oxygen, admit and observe. Now let's say that this patient is having shortness of breath also. You still want to aspirate, chest drain. Okay, because chest drain will be our main thing in case of secondary pneumothorax. Patient after a trauma having pneumothorax, like a secondary pneumothorax, 15% pneumothorax means that it fulfilling the criteria, right? So rim of air in chest X-ray more than 2 centimeter or more than equal to 15%, same. So this patient already having that. Even if there is no shortness of breath, still according to the scenario, we can go for chest drain, okay? Sorry. So chest drain will be main management for a secondary pneumothorax. Now let's say I change the question. I'm saying it's a 15% pneumothorax in a young person without no lung condition. Saturation 95. What you want to do? So that's a primary pneumothorax. For a primary pneumothorax, 15% pneumothorax means it fulfills this one, large but minimal symptom. The question is, do you want to give oxygen? No, because patient saturation is fine. So you just admit and observe at that time. Okay, so that's how you think about, you always think before you answer, because things changes all the time based on the question. All good? So that's all about our today's question discussion. Secondary is most of the time chest drain, unless if you get a patient who is not having shortness of breath, and also if the rim of air is less than 15%, in that case, you can do aspiration. So that's your first session on first 2 weeks free session. How did you guys enjoy? You guys can unmute yourself and talk to me after the class. That's fine. We normally keep the class muted because there is a lot of side noises happen if we just ask everyone to mute. Now you can always, now after the class, you can always talk to us, ask any questions. And also if there is any questions about the course, you are more than feel free to ask any questions that you are having. So just to give you an idea about our ongoing course, which is already started just now with you guys. So today is our first session, and this is a part of the course as well. So think about that you are already in the course. Okay, doesn't mean that you have to pay. You are doing the course class. So if I open our course description just for a moment. So if you see here, this is actually our course is a 5 months course. We include the full theory, which includes everything from your John Murtagh, Kaplan Step to CK, and also some other Australian guidelines. So full theory, there is nothing left in the theory. We also do the recent exam-based practice question solvation. There is one class every week on question solvation and 2 theory classes. You have a software when you join the course where you get everything, your questions, your mock test, everything is in one place, and you get an unlimited mock test in the software. There are questions, like there are mock tests which are 150 questions, just like your exam. There are mock tests which is like a 50 questions, 25 questions. So you can solve as many questions as you want, and those are time-based. So you can see how good you are doing with the time. And you also understand how to maintain or manage time in the exam. You also get 4 years question solvation with explanation. Some are recorded, some are already solved, some will be discussed in our question solvation class. You get the access to the note until you pass the class, until you pass the MCQ, and you get a long 10 months video recording access even after finishing the course. And there is a lot of other things which I know I don't need to discuss about. There will be classes on imaging, CTG, statistics, ECG, a lot of other things are there. So that's a little bit of idea about the course. Okay, now we already started our admission. So if you want to get admitted, make sure you either email us or at least send me a message in the inbox so that we can start the process. It takes a little bit of time to get enrolled because we have to make sure your identity is verified. We have to approve you into the software. So it takes some time. So make sure at least take some time in this 2-week session. If you like the class, then start your enrollment. Okay. Anyone can join anytime during the course, but because I always say that joining a course in the middle, it sometimes may be confusing, but if you want to just go through the previous class recording and then join in September, that's fine. Dr. I don't know what's your name, but yes, we can do that. If you are late in the exam, in your class, then we have class recordings in your software, so you can always just go through that. And the 2 weeks free session recording will be given in your Facebook group. So you can always go through that if you miss it. The MCQ topics are vast, but mainly you have to have a good idea on medicine, surgery, pediatrics, psychiatry, gynae and obstetrics, ethics, biostat. And all the books will be provided. The soft copy will be provided in your when you join the course. Recordings are there, so there is nothing that you need to do it by yourself. You can just rely on us and have your preparation done.
Hello, doctor. If you can take few questions.
Yes, doctor.
As I understand, we have one more class that is free of charge. Is that correct?
No, there is like, we have a 2 weeks free session. So you have got a lot of others. Like I can see 2, 4, 5. There is 4 or no, 4 classes. Yes, there are 4 more classes which will be free.
Okay. Okay. And once these free sessions are over, how do we get access to your classes? Because now we are just using this Zoom. Yeah.
So once you get enrolled in the course, then we give you the Zoom IDs in your course, and you just join our Zoom session just like you are doing now.
All right.
The class
Thank you.
on the Zoom always.
Okay, thank you.
No worries. And the class schedule, the free weeks schedule are given in our Facebook group, which is your first aid AMC MCQ. So you can just have a look at the schedule over there if anyone haven't got that. And Dr. Niluka, how to subscribe? Subscription, usually like once you enroll in the course, we will show you how to subscribe. So you don't need to do it right now. After the course enrollment, you make your payment and then we will show you how to do the subscription in the software. And the study material you guys should follow for your MCQ preparation, especially obviously John Mutta. AMC handbook is still, I say that read it, because still it is a very old book. A lot of questions answer are not correct, but still there are some questions which will always come from handbook. So read the handbook at least once or twice. You will need some AMC or Australian websites and guidelines, RSCGP, RCH, those guidelines will be needed, which we will show you during the course. You will also need some preparation from USMLE Kaplan Step 2 CK books. Okay. Yes, you can see the repeat recording sessions. No, obviously, these recorded classes will be on the Facebook, even after 2 weeks free session. So we don't delete the recorded sessions, it will be here. Facebook link, yes, I will be able to do that, Dr. Niluka. The books will be provided by us, but if you are someone who likes to read the hard copy, then you have to buy it, like especially the handbook, especially you should have your JM, and maybe you can buy the Kaplan Step 2 CK. These three are only thing that you need, but others you can just go through online. In your software, we haven't started uploading any lecture yet, but yes, it will be uploaded from tonight. So you will get this lecture in your software, Dr. Sanjita. Yes, so Dr. Abdullah, the 2 weeks free sessions topics are included in the course. So you're actually doing the course sessions at the moment. No, for software subscription, you don't need to pay extra. This comes with the course enrollment. So if I join in September and want to give exam in December, can I get done all sessions prior to that? I would rather say that if you're planning for appearing exam in December, you should enroll now, okay? Because it takes some time. It is very hard to just have 3 months for your preparation. If you can, that's fine, but I advise have at least 5 to 6 months for your preparation. Yes, we will have a session, like we will do that epic verification, or like how you do the how you do this AMC verification process. There will be a session on your first few sessions on after the course is starting. So it actually a part of the course, we will do that. Any question, guys? So let me just give you our main Facebook group link so that you can join there. So this is on your chat. So if you just click on that link, you will get our Facebook group. And that's the active Facebook group that we have. You can have all information that you need there. All right, so that should be the end of it. The next free session will be on cardiology. So don't forget to join it. So it will be on 5th of July. So just day after tomorrow. Okay. Thank you all. Have a good night. We'll see you soon.